Room for Baby Perinatal Child-Parent Psychotherapy. My name is Evelyn Blank, and I am the Associate Executive Director at New York Center for Child Development and also the Director of the New York City Early Childhood Mental Health Training and Technical Assistance Center, otherwise known as TTAC. And I couldn't be more thrilled to be with all of you here today. Before we get started, I just wanted to run through a few logistics about today's webinar. And first, to start off by saying that as we've done in the past, this webinar is being recorded and it will be posted along with the slides to the TTAC website in a few days. We'll also be taking questions throughout the webinar, and we ask that you chat your questions using the chat box, selecting all panelists on the dropdown. We're going to set time aside at the end to really respond to these questions. For those LMSWs and LMHCs interested in obtaining CEUs, you will be eligible to receive 1.5 CEUs for attending this webinar. If you are only joined by the phone, we would need you to log on to the WebEx via a computer in order to obtain credit for the CEUs. Further info and instructions will be distributed via email to all of you following the webinar. And finally, towards the end of the webinar, we'll be sending out the feedback survey using the chat box. We ask that you click the link that is shared in the chat box and complete the feedback survey, and really appreciate you filling this out as it allows us to better understand your experience and enhance our future TTAC trainings. So just a brief word about who we are. The New York City Early Childhood Mental Health Training and Technical Assistance Center is funded through Thrive New York City, and it's in partnership with the New York City Department of Health and Mental Hygiene. TTAC is a partnership between the New York Center for Child Development and the McSilver Institute on Poverty, Policy, and Research. New York Center has been a major provider of early childhood mental health services in New York, with expertise in informing policy and supporting the field of early childhood mental health through both training and direct practice. And our partner is NYU McSilver Institute for Poverty, Policy, and Research, which houses the Community and Managed Care Technical Assistance Centers, CTAC, MTAC, which offer clinic, business, and system transformation support statewide to all behavioral health providers. TTAC is tasked with building the capacity and competencies of mental health and early childhood professionals through ongoing training and technical assistance. And just a quick screenshot of our website, and I would encourage people to go there where you can find our archived trainings and another variety, a lot of resources there. So we hope that you'll join us for future trainings and also make use of prior trainings that we've done. So it is now my privilege to introduce Dr. Alicia Lieberman, who's been really one of the major pioneers and leaders in the field of infant and early childhood mental health. And she's one of those professionals who combines clinical knowledge and insight with a deep sense of compassion, as I think you will hear today in terms of her work. She's the co-author of a book, Make Room for Baby, Perinatal Psychotherapy to Repair Trauma and Promote Attachment, which will be the focus of today's webinar. Dr. Lieberman is an Irving B. Harris Endowed Chair in Infant Mental Health. She's a professor and vice chair for faculty development at UCSF Department of Psychiatry and director of the Child Trauma Research Program at Zuckerberg San Francisco General Hospital. She directs the Early Trauma Treatment Network, a center of SAMHSA National Child Traumatic Stress Network, and is the senior developer of Child-Parent Psychotherapy, an evidence-based treatment for traumatized children aged birth to 5, broadly used nationally and internationally as an evidence-based treatment for traumatized young children and their parents or caregivers. Her research involves treatment outcome studies with traumatized young children from low-income and underrepresented minority groups. She is the author of The Emotional Life of the Toddler, which was described as groundbreaking and is now in its 25th year. She's also the author of numerous professional books and articles on early childhood mental health. Her work has been translated into several languages, including Arabic and Hebrew, and is used to increase understanding and foster dialogue between Israeli and Palestinians working with bereaved and traumatized young children and their families. Born in Paraguay, she received her professional training in Israel and the United States. Her cross-cultural experiences as Jewish Latina informs her commitment to increasing access and raising the standard of care for low-income and minority children and families. She is on national organizational boards and in 2019 was appointed to the California Early Childhood Policy Council. And in recognition of her outstanding contributions, she's the recipient of numerous awards, far too many to mention here, but most recently the Lifetime Achievement Award from 0 to 3 National Center for Infants, Toddlers, and Their Families. So Alicia, thank you, and I'm going to turn it over to you, and we look forward to a really exciting presentation. Thank you.
Thank you very much, Evelyn, for this beautiful introduction, and I am so happy to be here, honored to be here. I wish I were in New York in person, and we will make the most of it. I'd like to start by talking about how perinatal child-parent psychotherapy originated. Oops, let's see, I'm going the wrong way. Here we go. And why starting treatment in pregnancy matters. And I'd like to start with a bit of a history. About 15 or 20 years ago, we did a randomized study to look at how child-parent psychotherapy helped children and women who had been exposed to domestic violence. At that time, domestic violence was considered primarily an adult problem. And we made the point that witnessing domestic violence could be a very shattering, traumatic experience for a young child who depended on father for a sense of safety and protection. And indeed, we found out that doing joint treatment of the mother and the child reduced symptoms of aggression, depression, withdrawal in schoolers, but it also significantly decreased symptoms of depression, anxiety, and PTSD in the mothers. And these improvements, both in the mother and in the child, continue after the termination of treatment. While we were talking with mothers about their experiences of domestic violence, they told us in about 50% of the cases that the domestic violence had begun during pregnancy. And that made us sit up and the importance of pregnancy as a very potentially stressful developmental stage, both for the woman and the man, leading to feelings of irritation, stress that often were then manifested in physical aggression. And that is how the idea of starting in pregnancy began. We started with a group of women that were referred by the women's clinic, the OB clinic at San Francisco General Hospital, because of depression and anxiety, difficulty abiding by perinatal treatment, not coming to the pregnancy care clinic, etc. And we found that of those women that were referred to us, because they had that co-occurrence of domestic violence and mental health symptoms, there was also a history of childhood abuse, where while they were growing up, these mothers had a very high predominance of childhood physical, sexual, and emotional abuse, and it continued in the present victimization by crime, witnessing community violence, accidental injury, and loss of their attachment figures. Now, one thing that really impacted us was that only about half of the women reported that they continued maintaining a relationship with their partner, and only 26% reported having used birth control. And the reason I am talking about this is because we believe that reproductive health and justice and infant mental health and parent mental health all go together. And we have made it a point of asking mothers and fathers about their plans for family size, their plans for how big they wanted their family to be, and how do they go about implementing those plans. And we believe that that is a form of creating a safe niche for the baby to be born by helping the parents anticipate are their reproductive choices in the years that will come. Now, going back to why starting treatment in pregnancy matters, the sociological realities, the bottom part of this slide, are very stark in the United States. The rest of the world has made significant strides in decreasing maternal mortality. In the United States, we have actually gone backwards, so that maternal mortality has doubled in the last 30 years, and it has doubled while it was decreasing everywhere else, including in developing countries. The reason for the increased maternal mortality in the United States has to do with significant decreases in investment in public health in the United States. The costs of that decreased investment is something that we're seeing now. Pain that has been inflicted by the pandemic. The increase in mortality is particularly significant in racial and ethnic groups, and most significant among Black mothers and Black babies, with much higher mortality rates in this racial group than in other groups. So the sociological realities that I'm describing mean that when we provide treatment in pregnancy, we have to be very aware of the sociological circumstances of the parents that we work with and combine mental health interventions with concrete assistance in providing access to as good medical care as possible and to as good access to material resources as possible. There are also physiological and psychological challenges, regardless of the sociological challenges, but of course they interact. We know that couple conflict and IPV, intimate partner violence, domestic violence, increase during pregnancy. There are increases in substance abuse. There is often lack of social supports, and that is particularly noteworthy now. We are finding a greatly increased incidence of trauma during birth and of NICU referrals to the NICU for babies, and of childbirth that has medical and psychological complications as a result of the pandemic and as a result of women not having access to the resources and supports that they would have in ordinary times. And all of these challenges are happening in the context of the mother and the father having to recreate their own identity, not just as individuals, but as individuals that are now responsible for the life and well-being of a baby. So treatment in pregnancy has become a must for us. And what we have found in this work is that women that have a history of child maltreatment and witnessing domestic violence when they were young are more likely to experience postpartum depression, and that there is a comorbidity, co-occurrence of postpartum depression and PTSD in histories, in women that have histories of childhood trauma, and in turn, there is a greater likelihood of intergenerational transmission, so that these mothers are more likely to engage in child abuse, and these babies are also more likely to have negative perinatal outcomes, including um, um, low gestational birth, premature birth, uh, increased risk of infection, increased risk of not meeting the developmental milestones of the first 6 months of life, including failure to thrive. There is now a great deal of research, including in New York with Catherine Monk at Columbia University, who is one of the pioneers in this area, for a phenomenon that is called fetal programming, where it seems that alterations in the prenatal maternal stress is linked to alterations in fetal development. So that there seems to be a communication between the stress in the mother and the stress in the physiology of the fetus, which implications for the brain structure of the newborn, with markers of self-regulation, including something called respiratory sinus arrhythmia, which is difficulty breathing in response to stimulation that stresses the organism, which is in turn linked to increases in long-term risk for psychiatric conditions. So beginning in pregnancy can help both the mother and the baby with restoring a greater sense of physiological regulation with implications for psychological well-being. All of these materials is in our new book, Make Room for Baby, that Evelyn referred to. And we focus here on how psychotherapy during pregnancy can help to repair trauma, repair maternal and paternal negative attributions to the pregnancy and to the baby, and prepare them to welcome the baby in a way that celebrates the baby rather than considers the baby one more stress in their already burdensome lives. Perinatal psychotherapy is, like parent psychotherapy, a multi-theoretical and integrative approach. In child-parent psychotherapy, we have been very influenced by a psychodynamic approach to treat the ghosts in the nursery model of Selma Freiberg, which teaches us that what happened to us while we were growing up continues to have an effect on who we are as adults, and that when we become parents, those early experiences are often reenacted in our relationship with our children. So child-parent psychotherapy and the application of child-parent psychotherapy in the perinatal period is a very integrative model that makes use of that intergenerational approach, but also focuses on how does the attachment between the young baby, between the newborn, and the mother and the father take place, and how can we use an understanding of the culture, of the values that the parents bring, of their roles in society. What is the role of a mother? What is the role of a father? What are the expectations for what a baby should be like? How do those expectations get manifested in the here and now? One thing that we have found is that the universal fears that occur in the first 5 years of life and that stay with us for the rest of our lives tend to get triggered when we become parents, particularly when we are expecting a baby, when we're pregnant. And early fears of being left, separation anxiety, of being unlovable, of being damaged, and of not being able to live up to the expectations of society, what Freud called superego condemnation, and what I like to call the fear that we're bad at our core. All those fears, fear of separation, fear of being unloved, fear of being hurt, and fear of being bad, tend to re-emerge under the stresses of pregnancy. And memories from the past of being maltreated, of being neglected, come back with full force, together with, for women in particular, the fear that the pregnancy and childbirth are going to threaten their physical integrity. And there is a very pronounced fear of death and physical damage in this period, in the prenatal period, that becomes increasingly more acute as childbirth emerges or approaches. And as a result of all these memories that are both mental, psychological, in terms of images that come back from our childhood, but also images that we experience in the body. When the baby's movement, for example, can be perceived as a form of abuse, when the fetus kicking can be perceived as a form of aggression, it creates what we call negative maternal attributions, where we have mothers say to us, this baby is going to be just like my husband, is going to be aggressive, he's going to be impossible. He just waits until I go to sleep to start moving around and kicking me so that he is not letting me sleep. And he does that on purpose. I am being verbatim here about the kinds of fantasies that pregnant women have about who their fetuses are. Other mothers tell us that they find their fetuses are very manipulative, in the sense that they respond by giving them, for example, this is something that a mother to be told us, giving them heartburn when they eat the foods that they really like, which are spicy foods, and that the baby doesn't like spicy foods and is making the mother pay for liking and eating spicy foods. There are many, many attributions like that that give us an inkling that for this mother to be, the baby is already perceived as trouble. And often there is a struggle wanting to love the baby and feeling themselves overwhelmed by feelings of fear, anger, and resentment about the baby. And in the perinatal model, we pay a great deal of attention to joining the mother in where could these feelings, these ideas about the baby, where could they have originated? And so we serve as guides for them in starting to remember what it was like for them to grow up and what it is like for them now in terms of their current circumstances and the kind of support that they get. Because the prenatal period is such a complex period, we use a variety of intervention modalities. We talk to mothers and fathers, and whenever possible, we include the father of the baby in treatment, but we make it a choice of the mother initially. When and how the inclusion of the father will happen, but we make an invitation to include the father from the beginning, provided the mother and father are together and provided the mother has a sense that the father will be involved, even if they're not together anymore, that the father will be involved in the child's life. And we are very active in teaching the parent about the process of pregnancy, normalizing the physiological stress, normalizing the memories that come, normalizing the fears, because in the process of normalizing, we also create internal physiological regulation. We also ask very explicitly about their culture. We're such a multicultural country, and very often there is a discrepancy, the difference between the cultural group, the racial group, ethnic group of the therapist and the ethnic or racial group of the parent. And so we express interest in their culture, their expectations, because the practices and the traditions for a healthy pregnancy and healthy childbirth are very culturally uh, uh, influenced. There are rich cultural traditions in every culture about what mothers should do, what they should eat, what they should not eat, how they should take care of themselves, etc. And we want to know that and be able to build on that. We also use body-based interventions. For example, diaphragmatic breathing, yoga, imagery, so that we help the mother in particular connect to her body and start reading the signals that her body is sending and using the body signals as ports of entry into memories from the past and helping the mother use breathing, imagery, uh, anything that helps create regulation to bring a sense of well-being. We also use interpretations, helping her understand what the connections might be between the feelings now towards the baby and the feelings that The mother head towards her mother, towards her father, towards her siblings, towards herself as she was growing up. And always, always, we look at what are the traumatic events they've had, how to get the here and now. We also provide concrete assistance with problems of living, housing, food, um, um, whatever it is that the parent needs. And we are ready for crisis intervention. For example, when there is eviction or when there is domestic violence, to step in and create a sense of safety to the extent that we can. Those of you who are familiar with the child-parent psychotherapy will know that we start treatment with what's called a foundational phase. And the foundational phase is really a way of getting to know each other. It's about 3 to 5 sessions, and we explicitly say to the mothers, is the mother that we start with, that we would like to have a chance to meet together for a brief period of time, 3, 4, 5, 6 sessions. It's something that can be flexible, to think together about what does the mother feel she needs, what can help her. And for that, she needs to know us. We need to get to know her. And so we're going to ask questions, and we're going to open ourselves to questions that the mother might have of us about what we can offer. And then together, we can think after 4 or 5 or 6 sessions, we can sit together and think, what have we learned about what is useful, about what the mother's circumstances are, about what kind of treatment would be helpful. And so during this period, we ask about the current circumstances, particularly about situations of safety. We ask about possible sources of danger. We ask about exposure to violence in the neighborhood and in the family. We also ask quite directly about how did this pregnancy happen? What are the circumstances? What does this pregnancy mean to you? Was it a surprise? Did you intend to get pregnant? Was it welcomed? And equally important, we ask, was it welcomed by the baby's father? Because in about 30% of the cases, we find that the pregnancy was not welcomed by the baby's father, and that the father actually left the mother on finding out that she was pregnant. And that can often be a very big emotional blow for the mother who thought that this pregnancy was going to be a way of bringing them closer together. So what the pregnancy is and its meaning is foundational period. This is when we also ask about reproductive practices and their plans for the future, and how they would like us to help or not be involved in their thinking about it. And while we are listening, therapists, what are the connections between the present and the past? Both traumatic events, but also for events, because we give just as much importance to angels in the nursery, moments in the mother's and also the father's childhood where they felt loved, when they felt protected. And we ask them how would they like to use these memories of lovingness, of protection, of well-being to take care of themselves as they become parents, and also to take care of the babies and create similar experiences as they raise the baby. The foundational phase culminates in what we call a case formulation and feedback session, where we say, could we try to put together everything that we have been talking about and think together about what is the most important priority for you? What would you like to focus on, and who will participate in the treatment? And this is one of the times that the decision of whether the father will be involved and how the father will be involved. Will it be in individual uh, sessions that happen individually with the mother and individually with the father, joint sessions, combination of both? This is all very flexible and very much dictated by parental preferences and by clinical considerations. In the case of adolescent pregnant women, for example, the question of whether the young teen's mother and father, whether they will be involved, how they will be involved. Those are very significant considerations because there are processes of separation individuation where the young teen wants to grow and become a mother, but also has strong feelings of dependency that are not only psychological feelings of dependency on the parents or on the mother, but also concrete dependency for housing, for material support. And so what is the grandmother's of the baby voice in this situation is something that is thought about during this period. Those of you who are familiar with child-parent psychotherapy will also be familiar with the CPP formulation triangle, where we use the feedback session to think together about how the past is affecting the present. We might say, for example, you told me how your father left when you were 6 years old and how your entire life you longed for a father. And you also told me that when you met the father of your baby, you had this dream that he would be a good father to your baby. And this hope was shattered when you told him with a great deal of joy and anticipation that you were pregnant. And he responded by saying that this is not what he planned, and he left you. And now it's as if that early pain and that pain now are coming together and makes you so sad for yourself and because you cannot give your baby the father that you wish you had. So that is, for example, just one of many, many possible links between the past and the present. But then we also build hope because we think of hope as the most important component of effective treatment, reminding the parent of the strengths, of the positive aspects in their life, of what they can bring to creating the life that they want for themselves and the life that they want for their baby. And so we bring to the situation what we observed as areas of strength. And we talk about, for example, in this case, which is an actual example of a clinical um, encounter, the therapist said to the mother, and together with that sadness, I also noticed how strong you are and how you came to this country as an immigrant, not knowing the language, not knowing anybody, fleeing difficult conditions in your country of origin. And look at where you are now. You have a job, you learned English, you have a home, you have friends, you found our program as a place that can support you with resources that are important to you. And you are a young woman with a great deal of your life ahead of you who came a long way in achieving your dreams, and that can continue for yourself and for your baby. And together we can think of how can you build the next step so that we are always the, 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 the third component of the triangle is a component of strength, resources, and hope. At the same time, we are very aware that the triangle, the formulation triangle during pregnancy, is not just for the mother as an individual, but it is also for the mother and her relationship to her pregnancy, and the mother and her relationship to the baby. So in one other example, where the mother was feeling that the baby's movements were an assault on her safety, the therapist said, how when you were a little girl, your mom hit you with a spoon and with a frying pan and with a belt, and how that was, how helpless you felt, how you kept trying to be a good girl and to please her, and nothing pleased her, and how your body still remembers how frightened you were and how much the beatings hurt. And you know, it's not surprising that now when your baby moves inside you and kicks and tries to be comfortable inside this very tight space of the uterus, it brings back those memories, and it's as if it was happening all over again. That is how the abuse that we had as we were growing up continues to come back when there are feelings in the moment that give us pain. And at those times, it's hard to remember that this baby doesn't yet know how to hurt, that he's really trying so hard to find space in the uterus, because those memories are so powerful for you that they get in the way of your thinking of your baby as somebody that is just trying to find the next step in growing. And together we can think, how can we connect to those memories? Help you find release from them. And to make space for your baby as somebody that is so dependent on you for safety and for well-being. Very often, those connections, mothers are flooded with emotion. And this is something that we have built slowly in the course of the foundational phase so that we don't say it all at once, but we are helping the mother focus on the feelings of the body and let herself go to what those feelings are connected to in the form of memory. And so in the triangle, we make a connection between the early memories and the pregnancy, the attributions to the pregnancy and the attributions to the baby. It's as if there is a permeable membrane between who the mother is as an individual, how she relates to her pregnancy, and how she relates to the baby. And then in the core treatment, after the mother agrees to engage in treatment with us, we go back and forth between the past and the present, between the immediate past, the current circumstances, the childhood, loneliness, fear, and rage, and we seek the emotional meaning of specific memories and fears. One mother, for example, said to me as we were remembering her childhood, which was a childhood of great loneliness, where she remembers her mother. She was the oldest of 4 children, and she remembers her mother expecting her to be the one who took care of her younger siblings, and she hated it. One of the memories that she had was being 16 and having a 3-year-old sister and going to the beach in her bikini in Southern California and trying to be sexy, and the 3-year-old running after her and saying, "Mommy, Mommy, don't leave me." And her saying to her sibling, "Get away from me, I'm not your mommy." And feeling so embarrassed that the boys at the beach would think of her as an adolescent mother and not pay any attention to her. And then out of the blue, she said, "I always had this," and this mother came to treatment because she could not love the baby that she was carrying. She came for treatment when she was 8 months pregnant, was referred by her OBGYN because she was not taking medication that she needed for hypothyroid condition. And she said bitterly, "I kept telling him that I needed treatment because I cannot love this baby. I cannot prepare the room for the baby. I cannot anticipate joy for the baby, even though this is a planned baby. My husband wants the baby. I thought I wanted the baby, but I feel nothing towards this baby." Doctor only saw it fit to refer me when he started getting worried that I was not taking medication for the baby. He didn't care about me. And that gave me the inkling that this sense of abandonment, of not being loved, not being cared for, was very present in this woman's relation to her pregnancy, and she was 42 years old when she came to treatment. So this was not a young woman. And then she said, I always had this fear that I would squish a little puppy or a little kitten or a baby, squish them real hard and kill them. I've always been scared of that impulse. I am terrified that I will do that to my baby. And at that moment, I had a choice of going with the aggressive impulse and trying to understand what she thought of the aggressive impulse. This was a woman that had a very long history as a member of a motorcycle gang, long history of substance abuse, but she had been recovered for 7 years. The memories were coming back, however. And so I went with the protective impulse because I felt that she needed to know that she was not just a potential murderer, that she also had a protective impulse, could be mobilized. And so I went with the fear that she had, which was a very um, welcome fear that this wanting to kill, squish a puppy or a kitten or a baby, that this was not a welcome impulse. It was not ego syntonic. I said to her, and you want to protect the baby from that impulse. And here we go back to the fact that shame and self-blame are universal responses to a traumatic childhood, to a neglected childhood. I am bad. I made it happen. I will cause harm. I'm dangerous. I'm unlovable. I'm not deserving of good. And one thing that makes all good therapy effective, whether it's CBT or uh, any of the other acronyms, CPP, PCIT, psychoanalysis, whatever it is helping people let go of false beliefs about how bad they are, about how undeserving of love they are, and connect them to early fears that they had in response to their difficult circumstances. When I said to her, and you want to protect this baby from that impulse, she stopped and she looked at me and she said, I never thought of that. I never thought that there was something else, that I wasn't destined to kill a baby or a kitten or a dog. It's belief that I am a to protect it. That means that I really love it. I didn't know that I could feel love. And I said to her, you know, love comes in many, many forms. And as you get to know yourself, and as you get to remember what stopped the flow of love when you were little, because you did not feel love, you will find new forms of love. But right now, the way your love for your baby takes form is that you want to protect this baby from that impulse. You don't want to hurt it. And, oops, let me just stay here for a while. And that in turn led in the next session to her coming in and saying, for the first time, I was able to buy some baby clothes. And I started looking at where would we put the baby's crib. She was 8 months pregnant at that time. But it was as if that realization of her being capable of protection was really a way of making room for the baby, buying clothes for the baby, finding a space for the crib for the baby. And another memory was wanting to take a knife and cut through her mother's stomach in order to get a third baby that she was going to have to take care of. And I said to her, you were so helpless about your mother's pregnancies. You had nothing to do with your mother's pregnancies, but you were the person that she turned to for the caring of the baby. And I can understand that feeling of what can I do to get rid of this? Because you were a child, being asked to take care of a child, not only of one child, but of the two children that preceded that child. And here again, it was a way of releasing her from this feeling that she was a terrible person for having these impulses of wanting to use a knife, wanting to squish. And I think that this is one of the real important lessons of perinatal child-parent psychotherapy using a psychodynamic lens. Not to be scared of the frightening images that particularly mothers bring to the treatment, but to use them as guides to the unconscious. One of the co-authors of our book, Make Room for Baby, Gloria Castro, she is a magnificent therapist, came to this work with a conviction that talking about trauma during pregnancy could be dangerous, and that when pregnant women went back to traumatic experiences, they risked compensating, being so flooded by overwhelming feelings of fear and rage that they could not get themselves together to create a safe space to take care of the baby. And she and I had many, many conversations about it. And my position, which was anchored in the work that I did with Selma Freiberg, was that the unspeakable has a way of emerging in the form of impulses. And that if we do not get scared of the impulse, but serve as a speaker for what the impulse is trying to tell us, what the impulse is trying to teach us about what the mother is struggling with. And if we wrap the impulse, the malevolent impulse, the destructive impulse, in a benevolent frame, in an emotionally supportive frame, the parent grows in her emotional. She, instead of having to fend off anger, fend off rage, and having it leak unexpectedly in the form of this fear of squishing or this fear of using a knife, it's like, that's where that comes from, that early fear. But now there's a difference. One of the main pillars of trauma-informed psychotherapy is differentiating between remembering experiences and reliving experiences, putting the past in the past and creating space for the present. For this mother, that realization that all these feelings that she was trying to fend off had a reason for being, in the way that she was neglected, in the way that she was abused, in the way that she was expected to do things that were too overwhelming for her at her developmental stage, and that she wasn't destined to reenact them now as a 40-year-old woman, that she had agency. That made for tremendous release in her emotional life. And in that process, she became very ready to take care of her baby. Loving, prepared, but we spent a lot of time preparing for childbirth, because one of the things she said was, if those doctors do things to me that I don't want them to do, I'm going to kick them in the chin while I'm lying there. And I said to her, I can understand we talked a lot about where these feelings come from, but I'm thinking that kicking your doctor in the chin will not be very good for you, because you are needing that doctor to be there for you. So would you give me permission to think with you about what you want for childbirth and communicate that to your OBGYN team so that they are prepared for the kind of childbirth that you want, and they don't take you by surprise, they don't impose anything on you. And she said, the one thing that I really want is for them not to put the baby on my stomach for bonding. I hate that bonding. I want to approach my baby when I want to approach my baby. I said, well, I think that's a very reasonable request. And she said, you tell them, because if I tell them, they're going to keep insisting and I don't want to yell at them. So that was a link between the therapy and the OBGYN team, where I was the translator for what the childbirth needed to be like to be safe. And thank goodness it was a safe childbirth. And then when the baby was born, she called me from the delivery room to let me know we're in the same hospital. And she said to me, she's pretty, but she's very greedy. And so that was a beautiful statement that she that was a good part of the baby, and she was very preoccupied with the issue of physical beauty. But there was also the dark side that remained. It's not that just because one does successful interpretation during pregnancy that this baby will be totally freed from the attributions. And she said she's very greedy. She wants to breastfeed all the time. And as she went home and I started doing home visits, she said, when she cries and cries and cries because she wants to eat, very often it overlaps when I want to eat, and she won't let me eat. And that in turn led us to feelings of hunger when she was growing up. But it also led us to the fact that even though she remembered feelings of hunger and could see why the pangs of hunger now were so disorganizing for her, that still didn't release the baby from being seen as an intruder when she wanted to eat. And so we were in a bit of an impasse because she would let the baby cry until the baby really got red from crying so much from hunger. And that is when we often have to think of what can we do here that is concrete assistance. And we talked about, could she change her eating schedule? No, I need to eat exactly at the same time. Hungry, it's her problem. She has to wait for me. At the same time that she was being a very loving mother, whenever it was that the baby wasn't hungry and that she wasn't hungry at the same time, the conflict was around eating. And she said to me, once my first husband took a piece of pizza from my plate and I used my my fork and put it through his hand in order to make sure that he couldn't take that piece of pizza to his mouth, and it stayed there for me. And I said, that really shows me how hungry you get and how nothing can interfere and what you are capable of doing when you are in that stage of starvation. And then her husband, who was participating in many of these sessions by now, said, I will feed her when you are hungry. We will start making sure that she can start taking a bottle. And so we introduced a bottle, and there was this coming together of the husband rescuing the situation. And it told us about flexibility in acknowledging the baby's agenda, acknowledging the mother's separate agenda, and trying to find bridges that were workable between agendas. Another component when the baby was a little older was how much she wanted to be with the baby, but she also wanted to be out to leave the baby. She was so scared that the baby could not manage without her. And here again, we talked about how babies might want the mother first and foremost, but they can also learn to love substitutes. And she remembered in the process an aunt that she loved who was a real attachment figure for her. And she was able to think of her husband as somebody that she could leave the baby with when she needed to go out. And that in turn relieved the impulse that she had every time she went by the church of leaving the baby on the steps of the church. We have a very mindful approach to termination, because saying goodbye recapitulates all the goodbyes that we had, all the painful separations that we had when we were growing up. And so during the separation period with Eva, we started, which lasted about 3 months. We started talking about what things were like at the beginning. And she started remembering her fear of squishing a baby, and looked at the baby, and she said, I can't believe that there was a time when I did not love her. Which really shows, I think, the extent to which her discovery of her capacity to love had become deeply embedded in her sense of self. And then she said, I still get angry at her, but I tell her afterwards that it's not her fault, and we make up. So this idea of repair was something that she also internalized. And as I asked her, how do you imagine it'll be like when she is older and she becomes more demanding? She said, she's like me. She can be very manipulative, but I will work with her. I won't let her do let her do things that will make her get hurt. So the protective instinct was really very upfront in her relationship with the baby, and that is what I could see in the form of treatment. And so I want to end this presentation by reflecting on the parallel processes that happen with us as therapists during the perinatal period. To idealize motherhood, to idealize fatherhood, that kind of keeps mothers and fathers to be, and mothers and fathers in general, prisoners of self-blame, shame, when they are not able to live up to the expectations of being unconditionally loving parents. And I think that normalizing ambivalence, going back to what Winnicott said about ordinary parental hate, the fact that in our most intimate relationships is when we are most in the grips, both of feelings of ecstatic love, but feelings of overwhelming anger as well. And accepting it and looking for a way of reframing the negative feelings, the frightening feelings, the angry feelings, in a sense of self-understanding and permission is really important. But in the process, because we ourselves as therapists are also subjected to wanting our patients to be unconditionally loving parents, we can't forget the importance of acknowledging and accepting ambivalence. And I remember once when I was trying to get Eva to be more loving to her baby, she said to me, you know, Alicia, you keep thinking of me only as a mother. Can you please remember that I'm also a woman? And that, yes, I love her, but I also really miss who I was before I was a mother. And I asked for her forgiveness. I said, thank you, lesson taken. Let's go, let's talk about that. So reminding ourselves not to identify so fully with the baby and with the needs of the baby, but to remember that the baby can tolerate ambivalence on the part of the parents when it is manageable. And if the primary needs of the baby are taken care of, will in turn help us with an integration of the ghosts in the nursery and the angels in the nursery. And this is how I want to end this presentation. I want to let you know that we have some research showing that there are significant decreases in symptoms of PTSD and depression and increases in loving parenting beliefs and attitudes. So it seems to really work when we do it as a group. And I want to thank here Patricia Van Horn, my partner all these years, and the wonderful team that is with me as we do this work. Thank you very much.
Thank you, Alicia. This was so powerful, and we actually have a lot of questions in the chat box, but I wanted to start by just saying thank you for a very powerful and rich presentation. I do want to encourage people who want to take a deeper dive to get Alicia's book. It's Make Room for Baby. It's on Amazon. And if you really want to get a deeper dive into this really important topic, I would encourage people to do that. And also remind people to please fill out the evaluation survey. So Alicia, there were a lot of questions about and kind of a lot of impact about maternal stress and anxiety and people concerned about when do you worry about it? What can you do? What are the implications? People talked about COVID. They talked about severe morning sickness. And I guess people were kind of looking for some kind of sense of how to address this and how to really kind of work with the mother during this period.
Well, I think that flexibility of attention is a really important thing. If a mother has severe morning sickness, that becomes the topic. That is why the foundational phase is so important, because the foundational phase allows us to listen to the mother and tell us what her priorities are. And we might have our own priorities, but unless we prioritize the mother's priorities, forgetting look for priorities and the mother's priorities, unless we have a partnership with what the mother needs from us, we are not going to go very far. And so the foundational phase is really a time for what I call the co-creation of a treatment plan, where we think together, what is the most important thing that you would like me to be of help with you for? And in the case of Eva, for example, one of the priorities was the question of how to get her doctor to do the kind of childbirth that she wanted at that time. And so I was a go-between between herself and her doctor. So, you know, these kind of questions, I always say that they cannot be answered generally, except to say, remember the specifics and attune yourself to the specifics, the specific emotional experience that the parent has, and how to be a helpful guide, a companion, a supportive, emotionally attuned person. And then think step by step. For example, are we worried about the mother's capacity? I was worried about this mother's safety in terms of the baby. Would she pull a knife at the baby? I kept watching her. I kept looking at what did she do with her anger. Could I assuage her anger? Yes, I could. So then the fear that she would bring a knife out to the baby was assuaged, and I thought, I don't need to do a CPS report. But each one, this is where the therapeutic moments come. Every moment is a moment of assessment, of intervention, and of looking at the outcome of the intervention. And so we have to be very patient with ourselves and with the pace of the treatment. And we also need to be very clear in how are we conceptualizing the needs of this mother and the needs of this baby, so that we are clear in the treatment plan.
Excellent, excellent. One question was, what can be done to promote bonding attachment between newborn and biological parent when an infant has been placed in foster care and has limited visitation?
We work with what we have. You know, therapy is the art of the possible. And I'm amazed at, let me give you this, this is not, the same situation, but I have been able to make a relationship with a baby who I have not seen since he was born. And now he waves at me at age 10 months on teleface. It's amazing what babies can do when there is profound attunement to them. And I think that concentrating on the magic of everyday moments, however short the moments are, and seeing what happens, because some babies can do it, some parents can do it, and others can't. And it's acknowledging the individual differences that is, I think, the key.
Great. Someone else want to know whether you had any thoughts about working with teen parents who have both historic trauma and also maybe living in a traumatic situation.
Yes, absolutely. This we do this all the time, and it is very hard work. And that is where the idea of having a foundational phase again, and we get to know the past, we get to know the present, and we get to think together when to pay attention to the present and when to pay attention to the past and when to pay attention to the interaction, the way that the past is being relived in the present and the way the present is being because of perceptions from the past. That is why the more we know about the ongoing impact of past experiences in present circumstances, and we go flexibly back and forth between inner life and concrete assistance with problems of being. I feel very grateful that Selma Freiberg was a social worker and a psychoanalyst, and that John Bowlby talked about reality, of reality, in inner life, so that we have a bridge between inner life and external reality, and we give honor to both in working with the parent, and we ask the parent to guide us also in when.
Someone asked, can you please speak about the mother who is helpless rather than hostile and who shows you fear with little memory of her own past?
I believe that we are all capable of anger in response to neglect and abuse. And I believe that it's really useful to think of helplessness as a form of learned accommodation to situations that robbed us of our sense of agency, our sense of power. And with helpless mothers, I think that sooner or later, it's very possible that they will show us the anger under the helplessness. And I'm saying that so that it doesn't take us by surprise. But I think that these are often parents that are afraid of their own agency and have squished it. But if we give voice to the right that they have to work for what they want, to ask for what they want, to take what they want, and if we join them in the asking and in the practicing, they will see us as people that not as in the face of their helplessness. I think one of the challenges of this work is that we tend to internalize the mechanisms that the parents are showing us. And when the mother is helpless, we become helpless. We become despairing. We become distrusting of our own capacity. We have to overcome that. And we have to step forward and say, we can do it. What would you like? How could we do it? What can we might not succeed the first time. How can we practice it until we succeed? So that the hope and the proactiveness are really front and center in the way we convey a sense of possibility for the parent.
Terrific. So one last question. Someone wondered, when would you recommend referring a family for PCPP? What criteria would you use?
Whenever a parent expresses fear, anger, lack of love, lack of hope, lack of being prepared, and PCPP can be 3 weeks, can be 2 years. PCPP is really an attitude of wanting to hear what are the roots of the difficulty, the presenting problem, and how can we work together to establish an approach to a solution. One, Gloria Castro had a situation where the mother was referred because she could not give a name to her baby. Another baby that she miscarried that did not. And in 4 sessions, this mother could give a name to this baby, could cry for the baby that did not have a name, and could move forward. But it was staying with her until she could tell us what were the difficulties, what came to her mind when she tried to come up with a name for her baby. It was that simple question that led her to telling her secret of the baby that died, that she could not tell. And that's why we're such believers that looking for what is unspeakable and how can we give it expression, that is the road to freedom.
Alicia, thank you so much. This was such a rich presentation. Someone wanted me to mention the name of your book again, Make Room for Babies. So I'm holding up for a moment. And thank you. This has been so informative and so powerful.
Thank you very much, Evelyn, for having me. And I wish I could see the audience. I wish I could relate to you all. Thank you for being here together. Bye-bye.
Thank you. Thank you. Bye-bye.